Hello everyone, welcome back. Today we are starting our healthing topics for AMC Part1 exam. So we will begin with adult medicine respiratory system. It will take 2 to 3 sessions to cover the topics from this system. So let's get started. Our first topic, ABG. You need to memorize these normal values. In the exam, you will be given clinical stem along with the patient's ABG report. Then you will be asked either to manage the patient or to diagnose the type of acid-base abnormality. So the pH normal is 7.35 to 7.45, PaO2 80 to 100, PaCO2 35 to 45, bicarb 22 to 26, base excess -2 to +2. Here is one question for you. A 54-year-old man with a history of COPD is rushed to emergency department with increasing shortness of breath, fever and productive cough with yellow-green sputum. On examination, crackles and wheezes are heard in the lower lobes. He is tachycardic and has a bounding pulse. ABG shows pH 7.3, PCO2 6 to 8, bicarb 24, PO2 60. So from this term, it is clear that the patient is a non-case of COPD and he is in acute exacerbation. The cause may be an infection because he is having fever. In acute exacerbation, what happened? There is increased risk of carbon dioxide retention and that will lead to hypercapnia. So in this patient, the PCO2 level is 68, which is very high. The normal value is 35 to 45. And the PO2 is 60, which is decreased. Normal value 80 to 100. What about the pH? It is 7.3. It is decreased. That means patient is in acidosis. What acidosis? Respiratory acidosis. Now, what about the bicarb? It is 24. That means it is normal. Normal value is 22 to 26. So what can we infer from this with this normal bicarb report? It suggests that the patient is in acute presentation and the acidosis has not yet been compensated by kidneys. So the renal compensation typically take 24 to 48 hours to happen and the kidneys respond by increasing the bicarb reabsorption. Reabsorption will increase. Bicarb reabsorption will increase and H plus secretion will increase. So bicarb reabsorption will increase, H plus secretion will increase by the kidneys. But in this case, the bicarb level is still normal. So the compensation has not yet been started. So the diagnosis in this case is uncompensated respiratory acidosis. The next question, a 34-year-old woman had difficulty being aroused from anesthesia 2 hours after surgery. She had been given intravenous morphine sulfate for post-surgical pain. Her respiratory rate is 7 and she is breathing shallowly. The patient is unresponsive to all stimuli. ABG analysis shows pH 7.35, PCO2 70, bicarb 29, PO2 70. So in this case, the patient underwent a surgery and she was given IV morphine sulfate. Now she is unresponsive and her respiratory rate is only 7. So this indicates the patient is in respiratory depression, most likely due to this opioid administration, morphine administration. So in respiratory depression, what will happen? There is a risk of hypercapnia due to carbon dioxide retention. And in her ABG report, the PCO2 is very high, normal value 35 to 45, and it is increased. The PO2 is decreased, normal value 80 to 100. So her PCO2 increased, her PO2 decreased. So in such cases, in such hypercapnia cases, what we would expect, a low pH. But look at her pH. It is almost normal. The normal value ranges from 7.35 to 7.45. So it is almost normal, but towards the lower limit. Now look at her bicarb. It is 29, slightly increased, normal value 22 to 26. So what happened here? This slight increase in bicarb is likely helping in normalizing this pH. So what is happening here? The kidneys have started compensating for respiratory acidosis by increasing the bicarb reabsorption. So in this case, the answer is compensated respiratory acidosis. So the next topic, pulmonary function test. In the exam, you can expect a clinical stum with either spirometric values or the flow volume loop diagram. Then you will be asked to either make a diagnosis or to manage the case. So in the spirometric values, the three most important values you need to focus are the FEV1, FVC, and FEV1 by FVC ratio. So in the exam, you will be given both the measured and the predicted values of these parameters. And based on the report, you will asked to determine whether the patient is having an obstructive lung disease or restrictive lung disease or a normal lung function. So in such cases, the first thing you should do is you look at the FEV1 by FVC ratio first, and this will help you in categorizing the patient into two groups. If the ratio is low, the patient is likely has an obstructive lung disease. If the ratio is normal or high, there are two possibilities. Either the patient is normal patient or with a normal lung function, or the patient is with restrictive lung disease. So what do you do next to differentiate between normal and restrictive lung disease? You will then check the FEV1 and FVC values. If both are decreased, then you can categorize the patient into restrictive lung disease. If they are normal, you can categorize the patient into normal lung function. So when FEV1 by FVC ratio is normal or high, there are two possibilities. Either the patient may be with normal lung function, or the patient is having a restrictive lung disease. So you need to check the FEV1 and FVC values, and if both values are decreased, the patient is having a restrictive lung disease. If they are normal, the patient is having a normal lung function. Now you have two major obstructive lung disease. What are they? asthma and COPD. How will you differentiate between asthma and COPD? You will do a post-bronchodilator spirometry. So what is the usual procedure? First, you will perform a spirometric test on the patient, and this is called pre-bronchodilator response. And then you will administer a few puffs of short-acting bronchodilator to the patient, and after 10 to 15 minutes you will repeat the spirometric test. That second test is the post bronchodilator response. So if the patient is already on bronchodilators, what should you do? In that case, you should ask the patient to stop the bronchodilators before the procedure. If the patient is on short-acting bronchodilator, then you will ask the patient to stop the drug 6 to 8 hours before the procedures. If the patient is on long-acting bronchodilator, you will ask the patient to stop before 12 hours of the procedure. And after this, you will do the first or pre-bronchodilator test. Now, what is considered as a significant response or a positive bronchodilator response? According to latest criteria, if there is a 10% increase in FEV1 value, you will call this as a positive response or a significant bronchodilator response. So if you get a positive response, what is your diagnosis? Is it asthma or COPD? The diagnosis is asthma. Asthmatic patients will show a positive response to the bronchodilator therapy or a significant change to the bronchodilator therapy. What about COPD patients? Will they show any response? Or there is no response? They will show the response, but the response will not be a significant response similar to the asthma patients. So if there is a positive or significant post-bronchodilator response, the diagnosis is asthma. Another important thing is, according to previous criteria, the value is 12% increase, now it is 10%, and there is no absolute FEV1 value in the latest criteria. And for the children, they are still using the old criteria, the 12% change. That is another important thing. So the next topic, pneumothorax, another important topic. What is pneumothorax? The presence of air between visceral and parietal pleura. So the two major headings, traumatic pneumothorax and spontaneous pneumothorax. Traumatic pneumothorax due to trauma, either blunt or penetrating trauma, or maybe iatrogenic, following some medical procedures. So what is spontaneous pneumothorax? There will not be any precipitating event like trauma, but they are again classified into primary and secondary depending on underlying lung pathology. So if there is no underlying lung pathology, it is primary. If there is some underlying lung pathology, then it is secondary. Most commonly COPD patients, or there can be secondary pneumothorax, secondary spontaneous pneumothorax in asthma patients, interstitial lung disease, or cystic fibrosis. Should you do an inspiratory film or expiratory film in pneumothorax patients? Or both? Only inspiratory film is recommended in case of pneumothorax because deep expiration can exaggerate the size of the pneumothorax and it is generally not recommended. So, what is decompensated pneumothorax? Another name for tension pneumothorax. So, it is a medical emergency because there is a sudden large pneumothorax and that will rapidly compromise the patient and the patient's cardiopulmonary function will affect soon. So, what is the management? The patient will need urgent needle decompression followed by intercostal drainage. So, you need to read the signs and symptoms of this tension pneumothorax. I won't go into the details here. Where should you insert the cannula in the management? At the second intercostal space, in the mid-clavicular line, just above the third rib. So if this is second rib, if this is third rib, you will insert just above the third rib in the second intercostal space in the mid-clavicular line. So what I want to specifically highlight in this video is the management of spontaneous pneumothorax, because most of the students will forget the management of spontaneous pneumothorax to read. But AMC is nowadays keep on asking questions from the spontaneous pneumothorax. So we will discuss the spontaneous pneumothorax management. But before that, another important thing you need to keep in mind regarding this tension pneumothorax is there is a risk of tension pneumothorax in patients receiving the positive pressure ventilation, such as CPAP or BiPAP, like that. So there is a risk of tension pneumothorax in such patients that you need to keep in mind. So AMC's favorite topic, the management of primary spontaneous pneumothorax. Why this is such an important topic nowadays? Because the guidelines have changed now. Previously, the management was based on the size of the pneumothorax and symptoms. So, previously, if the size of pneumothorax is less than 15% and the distance between the chest wall and visceral pleural line is less than or equal to 2 centimeter, and if the patient is asymptomatic, you will discharge the patient. But this is not the guideline now. So this is the flowchart from therapeutic guidelines. So when a patient present with primary spontaneous pneumothorax, you will give oxygen if the patient is hypoxemic, and you will give analgesics if patient has pain. Usually there will be some pain in every cases of pneumothorax. And the next step is you need to check the hemodynamic stability of that patient. If there is any signs of hemodynamic instability, you will go for pleural intervention. What are the signs? Systolic BP less than 90, tachycardia, tachypnea, hypoxemia, or severe chest pain or severe breathlessness. So, what are the pleural interventions? Catheter aspiration or intercostal drainage. Catheter aspiration or intercostal drainage. if the patient's symptom improve after the procedure, you will observe the patient for 4 hours and repeat a chest x-ray at 4 hours. And everything is okay. If everything is okay and if the patient is stable after the observation, you will discharge the patient with a follow-up plan. Suppose if after intervention there is no improvement and there is a persistent air leak, or there is no lung re-expansion, then you will admit the patient with intercostal catheter drainage. Also, after observation, if after this 4-hour observation patient is worsening, or if the patient is showing any worsening symptoms, or the repeat chest x-ray is showing some persistent signs, then again you will admit the patient and put intercostal drainage. Now, if the patient is hemodynamically stable from the beginning itself, you will observe the patient for 4 hours, and if the patient remains stable and everything is fine, then you will discharge the patient with a follow-up plan. But if the patient's condition deteriorates during the observation, then you will proceed with the pleural intervention. You usually follow up the patient every 2 weeks until the pneumothorax has resolved, and the patient should be advised to report immediately if any symptoms recur. If the pneumothorax has not resolved within 8 weeks, you will refer the patient to the respiratory specialist. Also, if there is any recurrence of symptoms, you will refer the patient to the chest physician. Now, the management of secondary spontaneous pneumothorax. So, the initial management is same. You will give analgesics and you will give oxygen. But then you will do pleural intervention, and then you will hospitalize the patient for observation. Usually you will put intercostal catheter drainage because most of the cases the catheter aspiration is less effective in secondary spontaneous pneumothorax. Another thing you need to keep in mind is if there is any untreated pneumothorax, you should not put the patient on positive pressure ventilation. Why? There is a risk of tension pneumothorax. So what are the different pleural interventions? Urgent needle decompression, catheter aspiration, intercostal drainage. Urgent needle decompression for tension pneumothorax, and other cases you can do catheter aspiration and intercostal drainage. So the catheter aspiration is also known as thoracocentesis. And how is it done? I won't go into the full procedure, but using a small bore catheter or a pigtail catheter, you insert into the intercostal space above the 5th rib in the mid-axillary line. So above the 5th rib in the 4th intercostal space, you will insert the catheter in the mid-axillary line, and you will aspirate until no more air can be withdrawn. Should you do a chest x-ray after this pleural intervention? Immediately after the procedure? Yes, an immediate chest x-ray should be done after the pleural intervention, and then you will repeat the chest x-ray after 4 hours. Now some special points. Pneumothorax of any kind and size should be treated with chest catheter if the patient is undergoing general anesthesia for any reason, or if the patient is planned to be intubated or mechanically ventilated, and the patient is planned to be transported by air. In these cases, you need to insert a chest tube. So here is one question for you. A 22-year-old male present to the emergency department with complaints of sudden onset of left-sided shoulder and upper chest pain on breathing while playing football. He is tall and otherwise healthy and a non-smoker. His pulse rate 88, respiratory rate 14, BP 120/80, saturation 98. Chest X-ray confirms a small left-sided apical pneumothorax. Analysis is given. What is the most appropriate next step in the management? Option A, urgent needle decompression. Option B, reassure and discharge the patient with follow-up plan. Option C, observe and chest X-ray after 4 hours. Option D, catheter aspiration. Option E, observe the patient for 4 hours. What is the answer? So here the answer is option E, observe the patient for 4 hours. The diagnosis is primary spontaneous pneumothorax. Why? Usually in a case of primary spontaneous pneumothorax, the clinical stem will describe a young, tall, thin male. Here the patient is 22-year-old male and he is tall and he is otherwise healthy. He is a non-smoker and the symptoms appear while playing football. And his vital signs were stable and already given analgesics. And there is only a small left-sided apical pneumothorax. And there is no need of oxygen because his saturation is normal. So the next step in a stable patient is to observe the patient for 4 hours. So the answer is E, option E. If this patient remains stable after 4 hours, you can discharge the patient with a follow-up advice. So this option B, will come after 4 hours if the patient is stable. What about chest X-ray? Why the option C is wrong? Chest X-ray is only needed if the patient underwent any pleural intervention, which is not required in this case. So what about urgent needle decompression? This is the treatment of choice, first treatment of tension pneumothorax. And the catheter aspiration is required if the patient is hemodynamically unstable. So the option is E. Correct option is E. Observe the patient for 4 hours. So that's all for today. If you like the session, like, share and subscribe to my channel. If you have any queries, you can add them in the comment section. So thank you for watching.